What are some of the limitations of the ACE score? And I think this is really why I'm talking to you here today. What are the limitations of that score? The questionnaires commonly used to calculate the ACE score are really crude measures of the actual exposure to the biology of adversity. About 15 years ago, I developed this one-page thing that I called Finding Your ACE Score. The purpose of that was to teach audiences like this one here today and professional audiences about, number one, what were the types of questions that we used to ask about adversity? And then I had the people in the audience fill out this questionnaire and get their own ACE score. This is a pretty accurate compilation of the original questions that we used for the actual ACE study. And what I found is in those professional audiences, the ACE scores of those audiences were always higher than the ACE score in the original ACE study. So it was a way of teaching. Number one, it's a teaching tool. How did we ask about adversity? And it also taught under controlled circumstances in presentations or seminars about ACE scores are everywhere, that it's not just people out there. And that was especially important for a professional audience to understand that ACEs are in the room. And so I developed that as a teaching tool, and it went out on the internet. And the internet being what it is, it's been adapted for uses that we need to talk about. Why is this tool and the tools that are being used adapted that are similar to this, that have taken this and modified it somewhat and being used for screening, why is it crude? The questions commonly used to measure ACEs cannot adequately assess the frequency. How many times did these adversities happen? The intensity of that experience. How intense was the adversity when it occurred? Was it chronic? Did it just happen once or twice or every once in a while? Or did it happen day after day, week after week, or month after month? We now know that there's gender differences in the impact of certain adversities, differences between boys and girls in the way it affects brain structure and function at different ages. And we have sensitive developmental periods growing up when certain adversities will have a greater impact on certain brain structures and function. And we also don't know what the individual variability is in stress response from asking this crude set of questions. So ACE scores are not created equal. Does that make sense? If it's a crude measure and one person fills out a questionnaire like this and another one doesn't, they have the same score, it doesn't necessarily mean that they've had the same biologic exposure to stress. So I want to give you a theoretical example of what I'm talking about. I'm going to go slow and walk you through this. This is a theoretical example that shows the relationship between a hypothetical biomarker for cumulative stress exposure and then relating that to the ACE score. So if during the ACE study we'd been able to get blood samples and there was some really precise and accurate biomarker for how much stress there was in that person's childhood, and we could plot that out, that's what I think this plot would look like. So we have the vertical scale would be what that biomarker looks like, that accurate biomarker for how much stress that person experienced during childhood. And across the bottom is the ACE scores. In this scatter plot, you see that the concentration of those biomarkers would vary pretty widely for every ACE score because that's a crude measure. We don't know frequency, intensity, severity, age at which it occurred. So let's look at, for that second set, the second scatter plot, ACE score of 1. There may have been people who had one ACE, one experience that occurred one time. Those people would have low concentrations. They'd be down at the bottom of that scatter plot. And then there might be somebody who had repeated abuse experiences throughout their childhood. They'd be up at the top of that plot. And the same would be true if we go to the right. Say, let's go to the ACE score of 6. Right? There may be some people that had 6 experiences of low frequency and intensity who would have lower concentrations of that biomarker, and there are some who would have had more frequent and severe and intense and chronic exposures who would be high on that plot. And then most people would be in that middle group, in between, somewhere around the average. So let's go back to that teen pregnancy plot. Here we see this graded relationship. And it looks really clean and smooth, and we can say that for an ACE score of 0, 15% of women had a teen pregnancy, and for an ACE score of 5, about 40% had a history of a teen pregnancy. Why does that plot look so precise like that? It's because it's an average. Right? So what I've done here is I've taken the relationship between the ACE score and a health or social problem that's represented in those sort of ghost red bars on top of the hypothetical measure, precise measure of exposure to stress. So what we see at the tops of those bars when we talk about risk is an average risk based upon how much exposure there was to the biology of stress. So ACE scores are not created equal, and it's not appropriate to apply that average risk from a big epidemiologic study to an individual person, because it's an average of that wide scatter plot of actual exposure to the biology of adversity. ACE scores have no standard, like a blood cholesterol measure or a blood pressure measure. And what we've learned in our culture is that we like to use those numbers, and that's a good thing. And we like to use those numbers because they've gone through a really intense research process. We have laboratories that standardize blood cholesterol measures. So if my blood cholesterol is 250 and you go to another lab and get a blood cholesterol 250, we're pretty sure that we're measuring the same thing. And the treatments that might be based upon that measure are based upon randomized clinical trials using a standardized measure. ACE scores don't have that kind of standardization, nor do they have the randomized clinical trials using a standardized measure to show that using the ACE scores actually has a benefit that outweighs the risk. So I'm going to talk directly from that about what I think are the current and emerging misuses of this score. The ACE score is not a diagnostic tool. It's not an appropriate screening tool because it's not standardized, and the measures being used to ask about ACEs are really crude measures. It doesn't predict risk at the individual level. It predicts risk for groups of people in epidemiologic studies.